Well, I want to thank you for a wonderful morning. We've had an ongoing summary of what it is that really comes into this question of cure, non-cure, wholeness in brokenness, when cure doesn't happen, the pain of that, the emotions, the issue of the rebelliousness of young people and some of the older people, Gary, and then the biblical perspectives, and that was really beautifully covered, Rudy. Thank you so much for that. Faith, hope, and healing. And as Dr. Handy Sides and I sat and exchanged a few comments, faith, hope, and healing, faith, hope, and love. 1 Corinthians 13. The greatest of these is love. And the other speakers emphasized that importance of love in each of these components. And then comes this interesting component called wholeness in brokenness. I often think of that beautiful hymn, Blessed Assurance, Jesus is mine. Oh, what a foretaste of glory divine. In one of the verses, Fanny Crosby writes, visions of rapture burst on my sight. But do you know that Fanny Crosby was blind? She was blind. And yet she could write, blessed assurance, visions of rapture burst on my sight. That is an example of wholeness in brokenness. And even coming to death, and I'm going to go straight to the chaplain, the commander, the friend, was a friend. You talked about it when cure does not happen. The next thing is Jesus. Reminds me very much when I was in family practice in my first mission appointment, where I'd been invited to be the pallbearer at one of the family members of one of my patients. And the local minister of another church who conducted the funeral asked if he could ride with me to the cemetery and back. And as we were riding to the cemetery after the service, I was talking to him and he said, well, what do you and your church, he said to me, believe about what happens when people die? I said, well, according to the scripture, Jesus said when people die, they sleep and will be woken up at the resurrection. I said, what do you believe? Well, even before I could say that, he said, I believe the same thing. Some of you know me well, better than I would like you to. And then I was much younger and a little less measured. And I shot back at him. I said, but that's not what you said to the people. He was a patient of mine and a friend of mine. Still after that. I said, you actually lied to those people. Because you took him from there and put him straight in heaven. And I was just worrying you were doing the same thing. Could you just elaborate a little bit for us on what you were talking about?
It is very interesting that you mentioned that story, because many times I have been asked to co-lead services with people of other ministers of other denomination. And it's interesting because many times they put them up and I bring them down. So, but it is interesting also because as we look at the Bible is very clear, and it says what happens when people die. The story of Jesus is very clear. And it's interesting because you have to be careful by respecting people's beliefs. At the same time, you need to be able to share what happens when people die. And when we look at Jesus and the story of Lazarus, the one that I referred to, at first, when they came and they asked him, well, he's dead, don't rush. He says, what? He's asleep. He said that several times. Then just before he arrived, he was asked, and he said, okay, he's dead. and then we have the resurrection. Now, one more thing is that as we look at many other faiths, especially Christian faith, other denominations, you'll be amazed to see that as the story that you just told, many believe the same thing that we believe, and many of them preach it that way. I was very, very impressed when I visited a cemetery back in the United States, an old cemetery in old colonial Williamsburg, and it was to a church of another faith, and there in the tombstones, these people that were not Adventists had written in their tombstone, "Here rests so-and-so until the second coming of Christ." So when you ask the question, what happens when cure doesn't happen? Jesus happens because Jesus is the cure, and he's also the healing.
And it's like a sleep, you know. I remember when I was a little boy traveling with my parents, and we would keep saying to them, "Are we there yet?" on a long journey. And you say to them, "Are we there yet?" And my dad would say, "Just go to sleep, and before you know it, we'll be there." And we would fall asleep. And the next thing we knew, we were there. And it's that kind of time relationship. I was so impressed, Rudy, and appreciated the structured approach of your paper this morning, and also the way you brought it in with some case studies. I wanted to ask you the question, when you deal with patients, do you find that you always take a spiritual history, a history about their religion, their religiosity? Do you do that as a routine, or would you recommend it as a routine?
I do it not as a routine in every patient, because I have also patients, they have otitis media or thing like that, some short things. Then I do not. But by patients which are seriously ill, or patients who have depressions or things like that, then it's a routine. And I recommend it really to take a spiritual anamnesis.
Why would you take a spiritual history? The importance?
Because patients normally do not tell from themselves these things, but they are important for their lives. They are important for their values and their hope even. You cannot suppose what they are thinking. You have to ask them.
Exactly. So what you're telling us is that it's important, and it's an ethical constraint, to not take for granted, and to rather understand and know what that patient feels about religion, spirituality, and I think that's a crucial thing that you brought out in your, that you implied in your case presentation, and I appreciated that very much.
I'd like to add to that. I know it all depends where you are, what countries you are, and what they allow you to do or not.
Tell us.
In some countries, they look at the spiritual needs of the person as a right. They have the right to be helped spiritually. So in some hospitals, in Florida Hospital, for example, everyone that comes in, they ask one question, and that is spirituality important to you? And if they said yes, the second question is, for us to serve you better, what is your denomination? If they say they are Catholics, then a notation is made, so we notify the local Catholic Church. We found out that some of them, even though they were not, they said, we are Adventist. And the reason why they say that is because they thought that being in an Adventist hospital, they will get a discount.
Those were really Adventists, I can tell you.
So it is something that it is required in many places to take that history to be able to serve their spiritual needs better.
As I was doing my training in the University of Geneva, I was very impressed by a remark from one of the teachers. He said, well, in psychiatry, we dare to ask many questions about sexual life, about what happened with your parents and so on, and we don't care about their religious life. And it was interesting to see that there was a team who made a research, They went in the ward in psychiatry at the public hospital and asked the patient, what is your religious interest? What are your religious interests? And then they would go to the nurse, to the physician, do you know something about this? And most of the time, the nurse, the physician didn't know. And when I heard this, I said, yes, we have not the right, but we have the obligation to ask those questions. And usually it is easy to do it when it's the medical history, because we ask all sorts of questions, and so it goes in the package. And also when we look for resources, what are your resources in your life? What helps you in your life? And of course, it's easy to add, are you a believer?
I love these answers we're getting because they are so practically important to us as we deal with people, as we work with people, as we relate with people. Because it's important to show that respect, that we acknowledge, not that it has to be the same faith as we have, but that there is faith, that there's a spiritual awareness, and a need to be cognizant and caring of that. Dr. Hopkins, Gary, my good friend, I don't know why you get the special service of a water bearer and all those things. I suppose they watered the camels in the Bible too, so it's wonderful. But so much of the discussion, as I listened, and I listened particularly carefully because I needed to ask some questions today, but I was also engrossed in all of what you had to say. You focused very clearly, and I want to make a little acknowledgement that Dr. Hopkins is probably more humble about himself than he absolutely ought to be. He has very focusedly, with a great focus, very intentionally, taken the subject of resilience in young people and run with this very, very important topic and brought it to the forefront of the church. He's been encouraged and enabled by visionary leader. But we really appreciate this, Gary. And I'm going to ask you the question. When we talk about relationships and young people, we need to let people know what is the how-to of the relationships. You mentioned the Kenyan story from Nigeria. And when he told us that story, I remember being in Kenya. Dr. Handy Sides and I were with Gary in Kenya, and he actually said to us, I'm tired of you fellows. You work too much. I'm going to bed. But tell us the how-to. You gave that wonderful illustration, but when each one goes back to their home, goes back to the real world, goes back to their churches, how is it that resilience is built in young people and in older people? So
there are actually some people here who have applied this learn their name strategy. I've had them come to me and say, you spoke in my town 10 years ago, and I tried it, and it works. And I've asked some of them, does it work? And they say, I don't know, but I sure like it. And now the kids come to me. You have to consciously pay attention to the fact that there are kids around you, and you have to consciously pay attention to the fact that you have to get to know them. Your personality is not going to match every one of theirs, but you can be available to any of them and all of them. You can make church the best day of the week. I was with some friends in Canada once, and I'd spoken at Canadian University College, I think they call it, College University. And they came down from Calgary. They were Catholic, and she'd gotten her doctorate at Loma Linda when I was there. And I asked them why their son, I said, Matt, little kid, 5 years old, he's moving around in his chair, like Danny Handysides would have, and he was moving around in his chair. And I said, what are you so excited about? And he said, I get to go to church tomorrow. I said, so what's so cool about church? He said, the people are really nice. 5-year-old. No kidding. Do they say that about your church?
What would you recommend people do? Should they know the names of the
Yes.
children in their church?
And then let it start from that. Just learn the names. Step 1, know who they are. Develop a relation. I tell you what, the fact that I know your name, if I'm walking by you on the street and you don't know my name, I'm not paying attention to you. If I got a beer in my hand and you don't know my name, so what? If you know me, the beer goes behind the back. It does. We change a little bit every time we get to know somebody. Everybody changes just a little bit. Some of us can change more in the good direction or the bad direction. You must see this. But we change based upon the people we get to know in life a little bit. You can be that little bit. And then you can make a big impact. And you're not going to usually know when you've made the difference. God will know. And the kids will usually know. And if can I tell a 30-second story? I had a girl got suspended from school in my hometown about 5 years ago. And I got suspended from school when I was in school, too. So I kind of knew what that felt like. That probably doesn't surprise Peter or Alan. And I went to her and I said something very simple like, look, this is not the biggest deal in life. This week's going to end. You're going to go back to school. You're going to forget about this eventually. This does not define who you are. And her parents came to me about 2 years later and they said, she had a suicide note written.
But your conversation changed the trajectory of her life.
I got to know that once. I don't know if I've ever said anything to other kids that have had a similar impact, but I got to know that one.
So,
and you can be that person. I didn't say much, Peter. I said a little bit. I didn't give her a sermon. I didn't criticize her for getting kicked out of school for drinking. I just said, look, this is not life. This is a part of life.
So basically, there are two components possibly. One is connectedness. You connect with them. We connect with them. You know, we're living in such a connected society. We have iPhones, iPads, everything, but we don't have eye contact. They walk around like this and walk into each other. So the first thing that Dr. Hopkins is saying, look at them. Make the eye contact. Know the name. And then talk to them. And speak. You know, I've learned something interesting moving to live in the United States. They speak a different English. But you know, there are some nuances which are very nice. In English parlance, British parlance, we say, I'm going to speak to you. I like the American way. I'm going to speak with you. I'm going to speak with you. I'd like to speak with you. It changes the trajectory from preaching down at someone to speaking with someone. We're going to come back to you, Gary. Drink some more water. Bernard, I really was trying to preempt some of your talk today, and as I'd written down CBT, cognitive behavioral therapy. Do you think Christians can benefit from cognitive behavioral therapy? Or is it a sign of failure of our faith if we need cognitive behavioral therapy?
Well, I believe that
it's not a trick question.
No. CBT is not a panacea. And usually, when you talk with a psychiatrist who is doing a more psychodynamic approach, more Freudian approach, who say, oh, it's a little bit boring what you're doing with CBT. It looks like more mechanical, where you will look at thought and so on. I personally see much good from CBT. The area where we have the best results is with anxious disorders, people with panic attack, with phobia, with obsessive-compulsive disorder. This is the hardest case. And also with depression. These are the areas where CBT really helps. Of course, when as a patient and a doctor or psychologist, we sit together, we look at the way the personality is built, the personality works, what are the reactions, the thoughts. Then we draw and we write many nice things. And sometime now, what shall we do? So this is when the supernatural power of the Spirit is very important.
That was beautifully explained. I really appreciate that. And as I first read about cognitive behavioral therapy, I thought to myself, this is what we as Christians really need in our daily living, to recognize the areas of temptation, to change our response to them, sometimes to move away from that temptation, whatever it may be that we need to do, but to be cognitive in the way that we deal with issues on a day-to-day basis. So this is a trick question. Is it good, or is it appropriate, or is it negative for Christians to go to counselors?
Well, you all know what Sister White said about it.
What did she say?
Well, psychotherapy is a tool in the hands of the devil. And you can read this in the Ministry of Healing. And I think it's interesting to know those thoughts and to know what she meant behind the word psychotherapy.
Explain that.
If you look at so it's on chapter 18, Mind Cure, and it's the subtitle is Control of Mind over Mind. And there we have the answer. I really believe that a psychotherapy where there is a control of mind over mind, then it is dangerous.
Including hypnotherapy.
Even with hypnotherapy,
Maybe.
okay, this is a big issue. There are some hypnotherapists, they say, well, it's impossible for someone under hypnosis to do something against their thinking. Personally, I would not go to see an hypnotherapist. And there are some Christian physicians or psychologists who say, well, we can use this, but I want not use it for myself and for my patients.
A Christian psychologist, how about that?
A Christian psychologist, I think, sometimes we need to sit close to someone that will confront us. And I think this is what is really different between a psychologist and a psychiatrist and a coach. And coach will say, okay, you go and you do this. A psychologist or a psychiatrist will just sit by and say, okay, what do you think? He will confront us with our reaction, with our thoughts, but they will not say what to do.
Thank you. I appreciate that. Now, in the background of that, Pastor Chaplain, Commander, is every pastor a counselor?
Well, first of all, I'm glad that you didn't ask me the question you asked him. Yes, well, pastors are counselors, but pastors need to be very aware of their limitations. I am not a trained counselor, didn't want to be one. I wanted to be a pastor. And people come to me, maybe I speak with them once or twice, but when I realize that, as we say in other areas, the situation is way above my pay grade, I make sure that I have a good Christian counselor that I can refer the person to. So as a pastor, you need to be able what you can do and what you cannot do, and make sure that you refer it forward.
Thank you very much. Now I'm going to ask a much more difficult question. It's difficult for doctors, for physicians, sometimes to think there's something they cannot do. Are physicians good counselors?
It may be.
They may be. My colleague here says that was a political answer. They could be, but I look back on a very broad career spanning family medicine, internal medicine, cardiology, private practice in the church setting, academic practice. And I think I did some patients a disservice by not recognizing the need to send them to a professional counselor. I'm talking about a Christian counselor. I'm talking about a Christian setting. Sometimes we are beyond our depth. We also have time constraints. But the reason I asked you that question is because you emphasized the message of hope. How do you do that with a patient in the clinical setting? It can be sometimes an intrusive thing to do. It can be a delicate thing to do. How would you approach a patient to give them hope?
I mentioned 3 points in my presentation. I listen carefully to the patient. I have to be aware of the foundation, of the ground of my own hope. And then I try to hear his story or to tell him a story of hope.
And I wanted you to repeat that because I so appreciated it came out so beautifully in your talk that you share the hope of Jesus. And I think that we are very sensitive, and it's something we have picked up in this conference of the variance of people's acceptance in various parts of the world of being willing to talk about spirituality in the clinical setting. But when there's a relationship, when people realize that you care about them, and you will have noticed that going through the themes of the talks this morning, relationships came up time and again. This important component of relationships. Now, Gary, when you talk relationships, is it only connectedness with one another, like you and me and Danny and Rudy and Bernard? Is it just a horizontal connectedness? No.
Sorry, I wanted to. Oh, no.
I'm speaking to this one.
No, it's a connectedness between groups. It's a connectedness between organizations. It's broad. It's not necessarily just a one-on-one thing. Though a one-on-one thing is a good thing. You know, I feel connected with you guys at Health Ministries in the General Conference as a group, and I think that's a good thing. It's not just one-on-one.
What modulates that connectedness? It's to a set of values in Jesus.
It is. And we have that in common, don't we?
And that is very important for us to remember. Sometimes when we talk about resilience and relationships, we tend to emphasize the connectedness between each other. But that connectedness is based critically on a set of values in Jesus.
I think it's important to bring up the fact that these relationships have the potential to be very good, but that they also have the potential to be very toxic. And a friend of yours, Alan, and a friend of mine, who lives in South Africa, his daughter went to church one Sabbath with earrings on and was told, I don't know how to say it, I guess I shouldn't say it, you look like and the word he used I think is not to be repeated from up here. And that's how she was greeted at church. Is that who we are? Are we the kind of people that want to scare people away, or do we want them at church? I don't know if she ever went back to that church. Did she go back?
She has gone back.
Do you know more about that story?
Yeah.
That's not who you want to be.
It took a while.
It took a while.
Yeah.
So that's not what we want in terms of relationships.
So it's a connectedness to one another and a connectedness to God, importantly.
I would like to ask a question.
They're ready to answer.
And to all of us also on the platform. Okay, we talked about choosing a Christian counselor.
Yeah.
There is a reality, at least in Europe, when there are not so many Christian counselors available. Yesterday I was speaking with a psychiatrist, Adventist psychiatrist in Germany, and he said, well, I think in Germany, I know maybe one other German psychiatrist, Adventist German psychiatrist. I have to say in Switzerland I know one or two, in France maybe one or two, and this is it. Okay, there are many more psychologists, but most of the time people are not paid back from the insurance, so it can be a burden. And so when we have someone needing counseling, shall we say, well, no, you don't go to see a counselor because we don't know the belief of that counselor? I think this is a tough question.
This is a very, very real issue. The lack of availability of people who are qualified and spiritually connected to faith. Mm-hmm. And I think this is a problem not only here. We find the problem, we have a psychiatric hospital in South Africa, which I'm associated with. To find Christian-oriented counselors is extremely difficult. And with that in mind, I'd like to just segue into the question, bearing that in mind, because we don't have people who are qualified enough. I know you have a passion for training people in chaplaincy. You mentioned the things not to say in the settings of a critical illness, a death, a sudden loss. How do we get that message across? Is it worth putting this on a website somewhere? We need to get the message through, because every church member should be a comprehensive health minister, a health educator. How do we get that message across? And maybe you could just reiterate that for us.
Well, I believe that to get that message across, we have to do training. A lot of training. And you don't have to become a trained psychologist or psychiatrist or a trained pastoral counselor to know those things. I spoke with someone after my presentation, and they were looking at how are we going to make this available to every church member. So being able to have trainings that we can get down to the churches to share those within the context of their culture, I think is extremely important. And the more I go around the world and we talk about these issues, the more I realize people are becoming more and more aware of what not to say in these situations. But even though we do have a lot of people that say the wrong things, but it's important to know what to say and what not to say. You cannot fool people, because they really know what's going on. They can think, they can sense that.
We talked quite a lot this morning about when cure does not happen. Now, how do we manage end of life? Analgesia. You know, I remember as an intern in 1974, where with terminally ill cancer patients, they would say, well, we're a little scared the patient may become addicted. I mean, they've got about 6 weeks to live or 3 weeks to live. And as I look back on that, I think of the injustices which we did by withholding. What should our approach be? Do you have any thoughts on that, Rudy?
For me, there is always a tension between the anesthesia and the awakenness of the patient. If you give morphines and things like that, you will have also sick, or also you do not feel well, you are more tired. Nausea, yes. And so there is a tension between that, and I speak with the patient, what is more of importance for him? To have no pain or to support pain and be more aware, more awakened. And we have to speak that together and to find the right doses of the medicaments.
In other words, there's an interaction where the patient is part of that decision making, but we do not withhold if the patient needs it and would like it. Please, Bernard. Thank you.
This is an issue that we face in La Linière hospital. Why? First, we have some terminal patients. We are doing oncology rehabilitation, and sometimes, unfortunately, rehabilitation doesn't finish with a return, a discharge to home, but it goes to death. And another issue that we have is in our county, in Switzerland, since January, there is this new law where the patient can ask for assisted suicide. And so where they have the right to say, okay, I can be in that place and take a portion that will be little, that will kill me, and I will die. And so we really need to give a good alternative to that. That's why palliative care is very important. If you can show the patient, yes, we have something better to give you, analgesia, also all the different symptoms, and there is some fine adaptation to medication necessary to that, all the support, and also spiritual support. It is well recognized worldwide that spirituality is part of palliative care.
Absolutely. Well, thank you so much. And I'm going to segue into that both to Mario and to Rudy on the issue of hope. You emphasized hope. Is it fair to give hope to someone when they are, you say to them, keep them in hope, tomorrow will be better? What kind of hope are you giving a terminal patient? How do we define that?
Well, if you tell them that tomorrow will be better and you know it's not, you're lying to the patient.
Okay.
So that's not the best course of action. But as
it's not a course of action.
it's not. They need to know what's going to happen, and we owe them. In the case of my grandmother, for example, when we delivered the news and we told her there is nothing else we can do, Grandma, she on her own. Sometimes we have to. The best thing to say is not to say anything and to let them come up. And she came up and began singing, "When my name is called up yonder." Of course, in Spanish, a different translation. The translation in Spanish is, "When my name is called up yonder, I will answer." Cuando mi nombre lo llamen, yo responderé. I will respond. But it is important that when we are at the last last stage is palliative care, to tell the truth, to help them understand. I brought my father to die in my house when there was nothing else we could do. And Gloria, my wife, asked him, "Dad, where are you?" And he said, "I am in Mario's house, and I am on my way to the cemetery." He knew. So don't fool them. Let them talk and acknowledge where they are.
You see, I noticed in your video, and it was a typical, I think, North American approach, where the lady said, "Is he going to live?" And there was a circuitous answer. It wasn't a direct, it was, probably not, but there wasn't a direct. And I think sometimes we are doing a disservice when we are not honest, but we do have a hope, as was brought out. Your thoughts, Rudy, about the hope and the honesty?
Of course, you have always to be honest. You have not to improve or strengthen false hopes. Hope is related to the future. And what is the future? Is it the day of tomorrow? We have perhaps less pain. You are not alone. There is a belonging. You stand it with the patient. Does the future end with the day of your death, or will come an eternity? That makes a very big difference. Is there the hope of resurrection or not? You can be connected with the patient, and you can show compassion with his real hard difficulties he have to go through now. But you have not to awaken false hopes.
That was also a beautiful theme that came out in the presentations, was the thread of compassion. The feeling with, the caring for, and Christ's compassion ultimately, which needs to work through us and through our relationship with our patients, with the people with whom we come in contact, the people we serve, the people that we as church members visit, that understanding that they must have that we love them. Gary, before we go to...
Yeah, I wanted to make a comment that had something to, a parallel to the question about anesthesia.
Are you going to talk about something other than young people?
Yeah, I am.
Okay.
I'm going to ask you a question, actually. 'Cause I'm sure you've seen this before. I used to get calls from patients of mine. I remember one night it was a nursing home, and she was 93 years old, and she was on oral medication for diabetes. And the family brought in a box of chocolates to give to her. And the nurse called and said, "Now, can she have the chocolate? You know she's diabetic." I said, "Give her the chocolate. We'll follow this lady is bedridden. She doesn't have much quality of life. And chocolate, I think we can deal with this. What do you think? Because I think you got to make this decision standing on your feet sometime, right along with the anesthesia question.
There's a very wonderful record in the scriptures where it says they asked him a question to trap him. And they said, "What sayest thou?" Give her the chocolate. And the fruitcake. You know, I think that we so often, when we come to the end, thank you, Gary, for bringing a reality into our, and a balance into how we approach things. We need to realize when people are at certain stages, it's not the time to start talking about milk, sugar, and eating in between meals. It's the time to look forward to the celebration of life anew when Jesus comes. Thank you for that. Questions? We have some very patient questioners who've come to the microphone, and they are all remembering the counsel that it's a short question, no sermons, and one question per person. Latvia, my brother.
Thank you very much. At first, thank you for such a marvelous European conference on healing. My question is, can we speak about healing for mentally sick person? And if yes, just not the second question, but part B. If yes, how can we minister idea of healing, communicate idea of healing to the mentally sick person? By mentally sick, I mean schizophrenia and something like this.
You mean what?
Schizophrenia and something like this.
Okay. I'm so glad we have all these very learned gentlemen.
I'd like to take a crack at that one. I do not think I'm going to give you the answer that you may be looking for, the right answer, but I can tell you how I have dealt with it. I was called, part of my training as a hospital chaplain, we take a residency. A couple of those 3 months units was in a mental hospital. So that was part of my work. I remember going into one of my mental wards, and it was a med-psych unit. It's a unit where the patients are there because of a medical condition that is the reason why they come into the hospital, but they are also psych patients. When I came in, the nurse said, her name is spelled E-V-A, Eve, like Eve in the Bible, and says, but do not call her Eve, call her Eva. That's the way she pronounced the name, Eva. Don't call her Eve, call her Eva. So I came in to visit with her, and guess how I called her? Eve, purposely. I said, Eve, how are you doing? She looked at me and she said, my name is not Eve, I am Eva. And I said, okay, Eva, how are you doing? And then we talked a little bit, and she said, do you know who I am? And I said, well, you tell me your name is Eva, and you're here in the hospital, and that's what I know. And she said, well, how well do you know your Bible? I am, and referring to a verse in the Bible, Eva, the mother of all nations. And then as we kept on talking, she said, do you believe me? And I said, well, I do not believe the same way you do. I believe different. And we kept on talking. About an hour later, when I was leaving, she looked at me and she said, you know, I'm going to stop telling the doctors that I am Eva. Within 2 days, she was out of the hospital, feeling better. But anyway, sometimes you, in my way of doing it, and you are the experts, you have to confront them. And you need to share with them. You respect their beliefs, but you also share with them what you believe. So I do believe that, yes, there is hope. I have ministered to many patients and that have psychiatric problems, and we deal with that, and we try to not to feed into their dysfunctionality, but to work with them as much as we can.
Thank you. Bernard, do you want to add something? We need to remember we have more questions.
Yes. So the question was healing for mental illnesses. Well, I think it's like asking, healing with cancer. You know, there are some cancer we can heal, some you don't. With mental diseases, there is always hope, of course, but it can be either healing, complete healing, it can be a stabilization, but I prefer the word recovery. And I think the US Department for Mental Health has really put a good impact on recovery. Recovery meaning how to live with one's limit. I strongly believe that for any substance abuse, I don't know what Gary would say about that, but for any substance abuse, I have hope. When I have a patient with substance abuse, I believe that if they would accept all the tools available and God-given grace, I strongly believe that there is hope for healing. For depression, unipolar depression, there is hope for healing. For bipolar disorder, I think there is so much biological aspect that there is usually a need of medication. For schizophrenia, there can be recovery, but often not healing.
Thank you so much. And I think you have taken us, the two of you have taken us through the journey of healing. Healing is not an end point. It is a journey. Cure is the end point. And we've been through all of those discussions quite a bit these last few days. So I think that just to add two other quick points on the mental disorders, mental health, we need to have it destigmatized. There must not be stigma on mental health. It is not a sin to be depressed. It is not appropriate for us as a church to shun people who may be struggling with this kind of issue. We are a hospital for sinners, not a display case for perfect people. And so part of the mental health approach, which is so crucial, and our time is short, is that we acknowledge it, that we treat them empathetically, lovingly, and do the things that have been mentioned.
I'd just like to add quickly. Also, we need to pay properly, because payment is one of the major problems why we don't have good psychiatry and psychology. We don't pay for the care that they need.
Thank you very much for the opportunity. I'm so impressed of the fact that as a Seventh-day Adventist we have a lot of information and knowledge about healing, about science, about medicine. We have a lot of professionals, doctors, scientists, and moreover we have faith, we have Jesus, we have hope. But my question is, as long as we have all of these things, why we are not able to say, sitting in front of the dying person or suffering by cancer or whatever, why are we not able to say, get up and go? Isn't it time for Jesus to act in this way as he did in Apostles' time, or we are still unhealed enough, or we still live in our sins and stop God to power the Holy Ghost to do that? Thank you.
Thank you very much. Anyone want to take that question?
Well,
You've got exactly about 30 seconds.
I like very much what Ellen Joy said. Praying for healing is a privilege that we should not avoid to take. It's a privilege, but there is no
Guarantee.
Yeah.
many times I ask myself, why did those miracles happen? Why?
Did Jesus not say so that you might believe?
Yeah, but not only that, Jesus said to Lazarus, come out, and he came out, but where is Lazarus today?
He went back.
He died. So there was a special purpose for those miracles to happen, and for us to believe. Jesus said it, for those of you that are here that don't believe, this is what's going to happen. Lazarus, come forward. So yes, there was a reason and a purpose for that, but we need to focus on the last days when Jesus will resurrect everyone, when we all will be healed, cured, when we all be restored. So that's where we focus more than anything. If we were raising people from the dead and curing people today, we would be more concerned and more happy about what we have done than the power of God.
And I think that basically sometimes we are a little hard and harsh on the church because we look for outward appearances. It's almost sometimes the way we look at each other's plates and figures as to whether they are eating the right things or weighing the right weight. I think that if we were to have all the healthcare professionals talk about the miracles of healing they have witnessed in their lives, we would have wonderful stories here at this meeting. So I believe that in God's way, He will allow this miracle of healing to take place. He will empower His people with the power of apostolic times in His time. Not for us to set up a time when it will be given in His time. I don't know when that will be, but we ought not to also make excuses for not living absolutely committed, dedicated, relational lives with Jesus day by day. Last question. Thank you.
Yes, how can we discriminate people with emotional sufferings if the inspiration tells us that 9 out of 10 disease has the origin in the mind? So maybe we don't understand our own emotional suffering. Okay, I'm Cesar Souza from Brazil. I'm a psychiatrist. I worked 26 years for the Silvestre Adventist Hospital in Rio de Janeiro. And I have just a comment. Now is my friend. We work together in the workshop about emotions. And yes, there is a difference between, I will finish in 1 minute. Okay. There is a difference between counseling and psychotherapy. I'm not going to explain this. It's not the time to talk about that. But Dr. Bernard David, he told a very important thing here, but I want to just to add something. God, the Bible, and the Spirit of Prophecy are not against psychotherapy. I mean, the type of mental approach that is condemned by God, both in the Bible and in the book of Ellen White, is when the professional try to control the other people's mind. This is the problem. Yeah, but counseling, psychotherapy is a process of trying to help people with emotional sufferings using words to elevate the person, to help the person to get insight, to help the person to understand, why do I feel the way I feel? Why do I say no when I should say yes, whatever. So it's to help people to live a best mental quality of life. Thank you.
Thank you so much. And we appreciate that. I want to thank each one. I wish you were asking that question of me, the first part, because we may not ignore emotional disorders and illnesses. But I want to thank each of the panelists for an outstanding morning, an outstanding time, the knowledge, the experience you have shared, and to thank you for being a most wonderful audience. I'd like us to stand as we close with prayer on a very, very special session. Our gracious, loving Heavenly Father, although this has been of a high academic level, the presentations have been outstanding. It has been crowned by the palpable presence of your Spirit, an awareness of your nearness. There are many questions going through our minds, and the questions that come because of our inadequacy when we view the ability of Jesus to heal. Father, help us to always remember that healing is a journey that will ultimately end in your kingdom. Help us to have perspective. teach us the elements of relationships. Kindle in us the fires of hope, and help us to be whole in our brokenness. We thank you that you love us and accept us as we are. We thank you also that you do not leave us that way. As we go into our lunch break and into the afternoon of relaxing time, we thank you for your presence and your healing power in Jesus' name. Amen. Thank you and God bless.